as we get going. We have Erin Eves with us tonight, who's a Hill College student. We have two new members of the medical community here in Fort Worth, Dr. Anania Majumber and Eileen Chu, who are both ENT surgeons, and they're both very interested in joining the Fort Worth Surgical Society. And we welcome you. Thanks for coming tonight. I think we're going to have a real special lecture. Now, you both went to medical school at Baylor College of Medicine. There we go.
This might be my lucky day.
There you go. Yeah. See, the stars are aligned.
Exactly.
We also, as always, want to thank our Moncrief partners for a being wonderful partners over the last 4.5 years. We can't say enough thank yous to Dr. Argenbright and his staff. Jonathan Louder Milk is with us tonight, along with Justin and Emily. I hope I got that right. Of course, Brendel. So thank you to our Moncrief partners. And all the lectures here. You'll get 1 hour of CME, and thanks, Dr. Duane, for filling out the form on time. This event is 346204. You can do it online or through your cell phone. If you do it right as you leave, you'll get credit. And we're recording all of our lectures too on our website, so you can look at it again afterwards. We're trying to work out where through UT Southwestern how if you go on the website, click on watch the lecture, if you can get an hour CME credit. We're working on that. This is your executive committee. I'm going to zoom through these. We're excited to have our next month's lecturer. You'll hear me mention this again. Dr. Philip Edmondson will be giving the first, heart, Dr. David McReynolds Service Heart Award, and he'll be talking about surgical education in the modern era, how to maintain resident autonomy. I had a long talk with him today. It's going to be a very good lecture. And without further ado, I can go over Dr. Duane's CV, but she knows what it is. She got a recent MBA in 2016, but she's had a long day and wants to get home. And her lecture tonight is going to be Defining the Cervical Spine Clearance Algorithm in 2017. I do want to say one thing before she comes up. We appreciate your commitment and your agreeing to be part of the Fort Worth Surgical Society. I know a lot of people are very excited about your being in charge over at JPS. We look for it's a great thing for our city. It's a great thing for our people. My youngest son finished the orthopedic program over there and was very happy, and he thought he was the best prepared resident at his fellowship in Tampa. So I think it's one of the best things that's happened to Fort Worth. That's my editorial. And without any further ado, Dr. Duane.
Thank you very much, Dr. Crawford. That's very nice. And it's funny because you're just like, the next step, what's the next thing I need to do is, I'm on call tomorrow, so I need to get home and get my swim stuff set up because I got a long swim before I take call. But when you're in the moment and you get to share almost a lifelong commitment. 12 years of my research was dedicated to cervical spine clearance. And in order to just save a little bit of time, one of the main themes of this talk has a lot to do with the building relationships in research. And so, although these are your take-home points, but I want to point out that the one about answering the clinical questions really takes a lot of time and dedication, but it's completely worth the results because it becomes personal for you. And research, for those of you who have done academics or have interest in academics and work with residents, is personal. And so you're going to see on a lot of the slides the references, and all of those human beings have touched my life very deeply, and I've touched theirs to the point that they're still friends of mine to this day, and I'll allude to some of that. So C-spine evaluation is really part and parcel of what we do as trauma surgeons, and I know there may be some people who will be able to see this on video, and for those folks who are in more austere environments, one of the things I hope they take home from this is really that they run this show. You can adequately manage cervical spine the vast majority of the time without requiring additional consultation. And I think that's an important thing to think about. And as trauma surgeons, we've done all the research. So it always seems counterintuitive to me to do all the research, see these people every day, admit 3,000 of them a year, and then go ask the ortho intern or the neurosurgical second year what I'm supposed to do with them. Made no sense. So really, that was one of the things that kind of really grabbed me about doing the research and looking at this. And we know that by generating the research and developing the evidence-based algorithms, people's care is better, it becomes more cost effective. And so this was a recent survey that came out from Australia where they said, what's the best way to look at these patients and treat these patients? And they found that there was a variety of protocols and practices which really could be problematic. So they said, we really need to standardize care. And my friend Ken Giannavi, who's over at LA County, put out with the Western Trauma Association this cervical spine algorithm. And it seems nice and simple, which is good. And I have a pointer, right? Does this point for me? I have to go there. Okay. And it's nice and simple, right? Blunt trauma, and I'll go into what Nexus is, and they keep it sweet and simple. Well, a girl has to complicate everything, right? So this is mine. Now, what I'm going to go through is the step-by-step through the algorithm, and I think you're going to come to appreciate why it says what it says, and actually that it's very similar to what I showed you with the WTAs. The difference is we complete the follow-through. We don't say this is what you do to diagnose. We then say what do you need to do about it. So first you need to look at why patients who meet TTA activation require some sort of cervical spine evaluation. So what do I mean by that? Well, the CDC triage criteria is very important. And as far as we're concerned from our algorithm standpoint, that's your starting point. That's important because there's going to be thousands of patients with little bumps and scrapes and bruises that come through your emergency department that never need to see me or see anybody in surgery for that matter. But when you raise the bar, okay, and you start meeting criteria put forth, that's when it's a game changer. It has everything to do with the incidence and the prevalence of the disease process. So these are the things that go into TTA criteria, just to give you a basis of understanding. So level of consciousness, anatomic injury, mechanism, and other circumstances. So what does Nexus say? And Nexus is going to be a major foundation that you have to understand prior to moving forward. Nexus was the National Emergency X-Radiography Utilization Study Group. Big publication in NEJM, was done in emergency departments throughout North America, and they had 34,000 patients. And basically they said that if you have a patient who meets 5 criteria, their neck doesn't hurt, they're neurologically intact, they are awake and alert, they're not obviously intoxicated, which is important because you're not checking alcohol levels on them at the time you're making these decisions, and they have no distracting injury, like their leg is hanging off and you're pushing on their neck and they're saying, my leg, my leg, my leg, then you don't need to do anything. You can clear their collar and be done with it. And this was so compelling that earlier EAST guidelines, EAST being the Eastern Association for the Surgery of Trauma, which does a lot of our practice management guidelines, said, you know what, you meet Nexus criteria, do nothing, take the collar off. Well, early in my career, I said, that doesn't make sense. And that's how a lot of my research was generated, when I found myself doing things that didn't make sense to me. And it didn't make sense because of this reason. You weren't comparing apples to apples. The Nexus rate of cervical spine injury is 2.4%, whereas our first study was at almost 10%. Andy Young, who is still a dear friend of mine, who I mentored all the way through residency, has written a number of papers, looked at our NTDB database, a major national database, and found a 6.2% rate, and WTA rate of cervical spine injury was 10%. So when you're looking at comparing groups, you have to make sure you're comparing the same groups. So what we did, we said, this doesn't make sense, let's start looking at this. And we did a prospective evaluation of our clinical exam. And again, the names you see here, Tracy Deckard, I mentored her all the way through residency. She is now a vice dean at Boston University. I'm very proud of her. Yes?
Dr. Duane, were these rates of false positives that you showed in the previous slide? For example, you're 9.7%.
No, that was your incidence of cervical spine injury in the study group.
Okay.
So,
all comers.
All comers. So my point is that Nexus includes a whole host of not very injured patients. And so when you're making value judgments on that, you need to make sure you're comparing apples to apples. Great question. So what we did was we set aside we started looking at all of our patients at the time and said, okay, well, these are the ones that are starting to meet Nexus criteria. They're awake and alert, the GCS of 15, the Glasgow Coma Scale, not drunk, no intoxicated injury. And we said, we found 17 fractures. And we said, okay, there's 17 fractures. How many of them were not identified by clinical exam? 7. That's a sensitivity of under 60%, right? So we're thinking to ourselves, well, we're not nearly as good as Nexus. Our incidence is different, and maybe we're not comparing apples to apples. Well, then we said, well, what if we compare Nexus to actually CT? Because in Nexus, they didn't do CTs. They just cleared collars, let the people go. So there was no real radiographic follow-up to see if they missed anything, and we don't have any downstream follow-up to confirm that people didn't go somewhere else paralyzed, okay? And when we looked at that, we again found that our sensitivity was very low at 60%. And this was another follow-up study. He was a medical student at the time. I still get Christmas cards from him and his wife who work in Chicago. And we thought the problem really is mechanism, because Nexus is, as you know, has no mechanism. Yet the CDC triage criteria says if you're in a bad mechanism, that increases your likelihood of having an injury, and you need to consider that. Well, our friends over the Canadian border looked at this and said, you know, if you include mechanism, we think you're going to be better than Nexus. And so it was true. The Canadian C-spine rule basically was 100% sensitive in identifying patients with clinically important cervical spine injuries. And what they found was that when they looked at their patient population and only looked at Nexus, they were only at 90%. So again, they were not reproducing the results that Nexus had put together in the first place. So we said, well, what does our data show? This was our third paper, and we said, well, you know what? The Canadian C-spine rule is very good. We did not miss one single fracture using it. And so we said, well, maybe we can figure out what we need to use as our triage criteria. And what we noticed was that there were 7 predictors of cervical spine fracture, and they're listed here. So we said, well, if we use that instead of our CDC triage criteria, maybe we can be good stewards of resources and really knock down the number of CT scans we need. But what we found was we actually missed a few fractures. And so based on that, we thought, well, maybe trying to funnel it down too small would increase your risk of missing injury. So when we did our final paper, we looked at over almost 10,000 patients and essentially found that only 66 or 0.7% of patients had none of the risk factors for injury. So essentially what that meant was that if you appropriately selected your patients, you would have a much better catchment. So that's why your incidence would go up. So at the end of the day, trying to narrow it down based on our 7 factors didn't help any, and it only added to the amount of work. Because consider if you've been in the trauma bay, I know we have an intern in the room. If you start saying, okay, does this person need it? Does this person not need it? Does this person need it? Versus, okay, they've met CDC triage criteria to be sick enough to come in with a collar, and you treat them all the same, you're much quicker, you're much more effective, you're much more streamlined, and you actually save resources.
So what happened to the 66?
They all got scanned.
Okay.
But what we were saying was if they didn't meet those, there were only 66 out of all of those patients that wouldn't have met any of the Canadian C-spine criteria. So because of that, we said, well, we're not going to use the Canadian C-spine criteria because it was a whole host of if you were hit at this rate of speed. And a lot of that already goes into the CDC, but the CDC is much more standardized. And that study, by the way, is the only one to date that has actually evaluated every single patient with a CT scan. So a lot of these previous studies just assumed they didn't miss an injury. So if we can agree that the trauma patient who meets CDC criteria deserves some sort of evaluation, I want to demonstrate to you why that evaluation needs to be a CT. Because back in 2000, the East Management Guidelines said, you know what, use 3 plain films, and you have a false negative rate of 0.1%. And those were lateral C-spine, AP view, odontoid. And for those of us who are a little bit older in the audience, we remember doing those things in our residencies before the PAC system, when we were the ones standing at the end of the bed, pulling the shoulders down, hoping to get a good view. So we said, that doesn't make sense. So we looked at this, and basically what we found was that if we looked at false negative rates, false positive rates with lateral C-spine, our sensitivity was less than 20%. So we were spending, at least back when I was a resident, we would take 3 or 4 lateral C-spines on every patient because it was inadequate, or it didn't get you all the way through that you needed to see. And think about the waste of time, the waste of resources, and it wasn't helping any. So when we looked further into this, we said, well, how, I mean, is there any value in this whatsoever? And out of 981 films, 3.1 were actually even evaluable, where the radiologist said, I can give you a read on this. 97% you couldn't give a read. Why are you getting that film? It's a waste of time, waste of money. We weren't the only ones that found this. Maggie Griffin up at in DC, same thing. Steve Gale, who's out in Tyler, same thing. Their sensitivities were so abysmal that we really said we shouldn't be getting these plain films any longer. So what happened when East updated the recommendations, and I was one of the co-authors of this, we basically said, get the collar off as soon as possible. And if you need to evaluate them, don't evaluate them with plain films, evaluate them with a CT scan. And the big issue is, the cost. Because people are like, well, if you're just getting scans on everybody, it's going to increase the cost. But this was a really well done study by Grogan et al., who, by the way, Moore and Jose Diaz, good friends of mine, very well respected, and basically found that if you actually just use CT scan because of your decrease in missed injury, the fact that you don't have to redo the films all the time, was more cost effective than doing plain films. So that argument doesn't hold up. So essentially our algorithm reads that if you meet CDC criteria for activation, you deserve a screening CT. And when you try and minimize it, when you try and use other methodology like the Canadian C-spine, almost all your patients have at least one risk factor, so you're not gaining yourself anything, and you're actually only adding more work in the trauma bay for the residents to go, do I get it, do I not get it, do I get it, do I not get it? So we really want to keep in mind that in trauma, everything's about efficiency and speed, because you never know what might be going on, and you want to be able to diagnose your injuries quickly. So keeping a clear cutoff that if they've already rolled into your trauma bay to be evaluated, those people get cervical spine CTs. Now, what if the CT of the C-spine is negative? It's very clear. Remove the collar. Because one of my huge pet peeves, which is what prompted a lot more of the studies, was why is it that we get a CT and it's negative, and then we press the person's neck to see if it hurts, and then we leave the CT, the collar on? When the people in Nexus said you need to get an x-ray if you have tenderness, so you did the film for the tenderness, you got the results that are negative, and now you're worried that they're tender. See, the circular logic would make me absolutely bonkers. And then I also saw all the problems with these prolonged collars. Migraines, muscle spasm, and that they had so much pain you couldn't then differentiate what was really going on with them. So what do? We looked at it. Pornima Van Bury is now a wonderful colorectal surgeon up in Massachusetts. Billy Weber just interviewed for the Baylor critical care residency. He'll be coming down here next year. Very excited about that. He and I did Ironman Texas together. Great guy. And all these folks have been just wonderful collaborators. So what we found was that the CT scan of the C-spine doesn't miss injuries. And we're not the only ones that have found this. This has been found over and over and over again. And as scans get better, this becomes even more obvious. We're just not missing these injuries. And this was studied at Shock Trauma back in 2005 when they looked at obtunded patients and started getting MRIs on all of these folks, and essentially found that MRI didn't add anything. That your CT scans were very, very reliable for ligamentous injury, such that you don't need to routinely get MRIs, which only adds costs. And of course, MRIs in most institutions are down the hall in the middle of the basement, and you're trying to take the sickest of the sick down there, and it's never a good idea. So what did these guidelines say? Well, in 2015, another update, they basically said that the overwhelming amount of evidence suggests that if you have a really good CT scan, you can clear that collar with the scan alone. So we're making progress, okay? Now, our most recent trial essentially had no patient with a negative CT who was later found to have a C-spine injury. And we are one of the few institutions that then published on our data where we did routine follow-up on all of our patients. We called them. So we know if we missed something, and we didn't. So that just kind of enhanced a lot of the work we had been doing.
Let me,
Yeah, sure.
Because the weakness of the CT scan was always thought to be the isolated ligament injury with no fracture. That's now not a problem based on your data.
Right.
Is that because of better CT scans?
It's because of better CT scans. It really is. And again, the CT scan is, and we'll go into it, but the CT scan is now reliable enough to say, I'm worried about it. And that, for those patients, you'll get a follow-up. They'll read suspicious for or can't rule out versus this is a normal CT scan. And I'll go into that data. So this is a meta-analysis that essentially looks at CTs to clear C-spines in the obtunded patient, because that was the other one that made everybody worried. Oh, I can't examine them. Well, I just told you you don't need to examine them, because if the CT scan's negative, it doesn't matter. And these are multiple studies that go on to demonstrate what our studies show, which is the specificity of CT scan is over 99%. So if your CT scan is negative, you do not have an injury. Cost effectiveness, another big issue. When this was a study that was relatively recently published in 2016, they looked at what's the most cost effective way of managing patients who you are worried about a cervical spine injury. And they found that without question, with negative scans, removing the collar is the most cost effective way of handling it. Why is that? Because MRIs are expensive and don't add anything. And when you're just afraid and you leave the collar on, it results in more films, more trips to the ED, more trips to clinic, more hemming and hawing. I had a girl come back, this was when I was still in Richmond, who had a negative scan. She had been to the ED 3 times because she was having searing migraines because of the collar. Her parents had taken 3 days off of work because of this. And all I had to do was take a collar off and tell her to get some physical therapy. But it was fear that was driving this, and the downstream consequences are huge. So I implore you, do not practice medicine out of fear. This is why we've created this data to help you. The other thing I identified when we wrote the paper was that, everybody's worried about, I'm going to get sued, I'm going to get sued. Let me say, I'm a trauma surgeon, I've been sued. I've won and I've lost, and it happens. And you just get up and you do the next right thing. And that was one of the motivating factors, because I was tired of people being afraid to do the next right thing for folks. And when I looked at what was published in literature, there was this one paper that essentially said more films do not protect you. Getting the films you have read correctly is the best way to keep yourself from being sued. So just more is not better. So CT is your gold standard for diagnosing injury. If it's negative, remove it, regardless of mental status. A negative CT scan is a negative CT scan is a negative CT scan. Now, if we move to the other side of the algorithm, now we have a CT scan that is not negative, okay? What do you do with it? It's just positive for some sort of injury. You have to now understand your risk. Because remember, in the beginning, I showed you that your risk overall, all comers, for those who are trauma activations, are about 7 to 10% for cervical spine injury. Okay, and this was Andy's paper where he said overall it was about 6%, fractures about 5%, ligamentous injury. Look at that number, 0.37%. So people are running around with their hair on fire, getting MRIs, or keeping folks in collars for 0.3%. And keep in mind, one thing I tell my residents and my medical students all the time, God made a great machine. He gave you 3 columns. You have to royally screw up 2 columns to make it an unstable injury. So even if in that 0.37%, it's a 1-column strain, it's still stable. So you have a lot of leeway. So what we found when we published our most recent study was that we were at about a 0.6% overall ligamentous injury rate, but, and this is where it's important to understand your risk, when we had a patient with an injury of any sort on CT scan, that rate went up to 10%. So it's a game changer, and that's what we're going to talk about. So with Andy's paper, the purpose of seeing this is to emphasize the fact that mechanism across the board is an important factor in determining risk, okay? Again, nexus, eliminated mechanism, which is again why it's not an appropriate methodology in and of itself. When we looked at what were the risk factors, these 3 things were the most important, and that's gonna be valuable because it's part of our algorithm. If, and again, after you find that you have a positive CT scan, if you're negative and you have a negative CT scan but you're tender, it doesn't matter. But if you have a positive CT for some reason and you're tender, or you have an abnormal level of alertness based on your DCS, or you have a fracture by CT, that is what jacks up your risk. So that's going to come into play. So as we look at understanding risk, these things come into play: the midline tenderness, GCS, alcohol intoxication. But again, mechanism all the way over for ligamentous injury, including MVCs, are going to be important and cannot be ignored. So if you've got a fracture other than transverse process or spinous process, and I'll explain why those are separated out, or your CT says it's positive for or suspicious for ligamentous injury, these are the patients who deserve a cervical spine MRI. Why is that? Well, because we looked at the other methods for diagnosing ligamentous injury, and in 2009, East was still saying, you could get a flexion extension film, and that'll help you. And that didn't make sense to us. And it didn't make sense to us because, again, we were noticing that it was very difficult to get good flexion extension films. And when I was a junior faculty at VCU back in Richmond, I noticed that people they would increase their hospitalization by 2 to 3 days, wearing collars, waiting for the most junior person on the team to go down to radiology to attempt to flex and extend the patient until it hurt. So you're telling me it makes sense to send the most junior person on the team to radiology in a dark room where no one sees you to see if you've got an unstable ligamentous injury? Doesn't make sense. So we said that doesn't make sense. So really, let's look at if this is a value. Well, first of all, it's important you have to understand, well, what's the proper technique? Most people don't know what that is. They have to be sitting and they have to be voluntarily flexing and extending their neck. And it has to go beyond 30 degrees. So we looked at this. We looked at our data. Nick Scarcella is a wonderful family practice doctor now in family medicine in DC. Justin Cross went on. They both did summer research projects with me and got scholarships for them. Justin went on to do surgery and is just an incredible gift. We found that when we looked at all of our flexion extension films, inpatient, outpatient, you can see that incomplete or ambiguous, defined as, again, the radiologist saying, I can't really tell you what's going on here, were pretty high. Again, waste of resources. So our incomplete defined as they couldn't actually go from C1 to T1, okay, or lack of full excursion was at over 12%. Ambiguous was the radiologist was not going to commit. So we basically had about a 20% overall rate and ambiguous rate of 9% in follow-up. So again, why are we doing it? It's not helping. So we eliminated those, and we weren't the only ones who found this. 2002, same thing. Both INSCO and Pollock was the follow-up study using the Nexus database and found a similar thing, that flexion extension added nothing. So we said, okay, well, what do we need to use? Well, if we're going to make the argument that MRI is the gold standard, these numbers are very low, but I'll show you some follow-up data. Essentially, even when you use flexion extension, it doesn't correlate very well with MRI. So you could be using flexion extension, it could tell you it's positive, you could leave them in a collar, and in actuality, they don't have an injury at all. This was a more recent study that put together some more data and essentially found the same thing, which was they had a false positive rate with their flexion extensions, giving them like a zero sensitivity. So why would you use those films? And so with our algorithm, we remove them. So if you've got, and so why is there a value of MRI? If you've got a CT that's concerning for ligamentous injury, when you look at your independent predictors of injury, your odds ratio is enormous. So you're 8 times more likely to have that type of ligamentous injury when it's positive. So just based on risk benefit, now those patients should get an MR. For CTs that are positive for fractures other than transverse process, they have about 11% incidence of ligamentous injury. So when you're looking at risk benefit, that's where the MRI becomes more beneficial than not evaluating them because the risk has gone up. So in the most recent study that we published, we had 57 patients with ligamentous injury. In our patient population, every single one of them had an associated fracture of some sort. And this is what's important, which is why we separated out transverse process and spinous process fractures, one of the reasons. When you separate out all fractures, if it was anything other than transverse process, you're almost looking at a 20% rate of ligamentous injury versus 2. So again, think about what your incidence is, and that's what should drive how you're evaluating these people. So the reason why in the algorithm we recommend a spine consult, because one of the other motivating factors for doing this algorithm was to eliminate unnecessary spine fractures. Why is that? It is extremely difficult to move trauma patients through the system when you're consulting 18 people for 40,000 different things that as a trauma surgeon, you are quite capable of taking care of. So we limit the amount of spine consultation we have, but if you've got someone who's got a fracture other than a transverse process fracture, that may indeed warrant some sort of intervention, okay? So that and the fact that it's a high risk for ligamentous injury is why that's included in the algorithm. Now, what if you've got a CT that's positive for injury and you only have an isolated transverse process or spinous process, but it's negative for ligamentous injury? Well, a couple things to think about. Transverse process and spinous process fractures in and of themselves require nothing. They hurt, but they don't need a collar. They have a smaller association with ligamentous injury, and because when you look across the board at cervical spine fractures, 50% of them are transverse process or spinous process. If you were to MR every single one of them, you would defeat your goal of trying to be a better steward of your resources. So it's this is where we now draw in the risk factors for ligamentous injury. So remember what we talked about earlier. In our study, in our most recent study, neurologic symptoms, midline tenderness, and a GCS of less than 15 were your biggest risk factors for ligamentous injury, and so that's what goes into the rest of the algorithm. So transverse process fracture, GCS of 15. It's very easy. If they're not tender and they have no neurodeficits, take the collar off. They don't need it. Those transverse processes will heal. They'll be a little sore. Give them some muscle relaxants and some nonsteroidals. If, however, you have a GCS of 15, you have midline tenderness but no neurologic deficits, this is where in our algorithm we recommend the collar for 2 weeks, which, by the way, was the routine way every single person got treated. You had people walking around all over the world with collars for 2 weeks that were disgusting, gross. They didn't know how to shower with them, or they took them off. They ignored you because they were smarter than you in the first place. And the reason for the 2 weeks is not based in evidence, because trust me, I explored what I could explore, and the only thing I could come up with is as it relates to bone healing. You are into the secondary phase, and theoretically, if the bone is healed, perhaps the tenderness along the bone no longer hurts, and the residual tenderness ligamentous. This is all presumption, folks. I could find no data on it. So that's why we limited it to that. So if they come back and their tenderness is gone, take off the collar. If they're still tender, then we will MR them, and if it's negative, we take the collar off. I don't MR them and send them to the spine surgeon to then take the collar off, because I'm perfectly capable of doing that. And again, you got to think, as we're being more and more evaluated for patient satisfaction scores, do you think it's going to make a patient happy to have to go to 14 different doctors with a collar? No. They want to see one person who's going to take charge and take control, and that needs to be the trauma surgeon. In the clinical scenario where the patient is a GCS of 15 and they're whether they're tender or not, if they have any kind of neurologic deficit, their risk of ligamentous injury is 6 times higher than anyone else. So they do need to have the MRI. And if it's positive, your first spine. If it's negative, you take the collar off and you give them physical therapy. Now, what if you have an isolated transverse process and you're negative, and you have a negative C-spine for ligamentous injury, but you're not awake and alert? This is where MRI at about 72 hours is important. It allows time for the sensorium to clear, so you can clear their collar without getting the MR, and it decreases the risks of long-term prolonged collars for patients, and it optimizes the value of the MR, because if you do it too soon, you have a higher rate of false positives, as shown here. Plackett demonstrated, this was published recently, that the earlier time to MR, the higher rate of false positives. So why 72 hours? A buddy of mine, John Como, basically looked at this prospectively and said the longer you leave the collars on, they had over a 5% complication rate when they were doing their MRs on an average of a week. So of course that's problematic. So the 72 hours is what we put in the algorithm, because it decreases the false positive rate. Because if you have somebody who now has a positive MR for a ligamentous injury and it's not unstable, they may be getting their collar prolonged with no benefit to the patient. They'll do just fine without it. So John Como standing up, AJ and Nancy. AJ was one of my partners at Richmond. We collaborate on a lot of these projects, and it's just a reminder for me that research is extremely personal, and you build these lifelong relationships, and it's one of the beautiful things about academic medicine. So this is our algorithm. It seems like a lot. However, if you just think through it, like we talked about, if I can get this thing to work, at the top, you've got that trauma patient who meets CDC criteria. You get the scan. If it's negative, take the collar off. And honestly, that's the vast majority of the people you're going to be seeing. So you can free them from that. If it's positive and it's something other than a transverse process, or it's concerning for ligamentous injury, get that cervical spine MRI. And if it's isolated transverse process, that's where we broke it down into, if they're not tender and they're normal neurologically, get the collar off. If they are, give them 2 weeks to recheck. If they've got neural deficits, get that cervical spine MRI. So it seems more complicated when you first look at it than when you walk through all this science. So as we compare what WTA had, which was the first smaller algorithm, to ours, you'll note that they're very similar. We both essentially exclude nexus criteria, because theirs really starts after the patient meets criteria. They recommend CT as the modality of choice. They recommend MRI for neurologic deficits, as do we. But the difference is they lack specificity with treatment. And we give you in our algorithm exactly what you should be doing, so that you only get spine consultation when you need it in a limited fashion, thereby saving the patient time and expense, and quite frankly, saving your hardworking colleagues who honestly don't have the time to deal with this. I mean, at John Peter Smith, I have no neurosurgical residents. Got some ortho residents who, cross cover, but again, I'm talking to the first year. It's wonderful. I'll teach them about my algorithm, but that's about it. And so it slows down care. So going back to the take-home points, it's really the CDC triage criteria. So people who are working out in hospitals that are level 3s or level 4s, if they have a person that meets CDC criteria, their patient should come in with a collar, and they can scan them and clear it if the scan's negative. Keep in mind that all patients with CTs of the C-spine that are negative should have their collars removed. Really, GCS only matters in the face of a positive CT, and these ligamentous injuries are very, very, very infrequent. Do not let them drive your management out of fear. It's really a rate of about 0.3 to 0.6 of all percent of all covers. And then perseverance really pays off. I mean, I started, when I was a resident, I started looking at pelvic x-rays and realizing, they added a lot of cost and time and expense and didn't add anything. We removed them from the established trauma bay films. We got rid of lateral C-spines because we realized those didn't matter. And now we've added this. And what's nice about that is that you then really can drive change in how you're managing, and you can teach residents not only better clinical care, but how to think through scientific questions and ask and answer them on your own, because then you own it. And then research really is a lifelong relationship, and it's a gift. Speaking of which, that's my husband. We actually do research together. He's the smartest human being on the planet. He's a transplant ID doc who's helping out Plaza actually with their program. And they're my 4 wonderful little rugrats, one of their communions, and at our music learning band. So on the side, I play trumpet with my kids, because he plays trumpet, she plays sax, he plays drums, and he plays bass, and it is a blast. So you can, do academics and write papers and have a family if it's what your passion is. And so, particularly for the young folks in the group, find what your passion is, because you make an impact, and you have the opportunity to spend some time with some wonderful folks like you. So with that, I thank you for your time, and I'm happy to answer any questions.
Dr. Duane, thank you very much.
Sure.
We do want to get you home to that wonderful family. I have a question, but before I open up, do we have any questions in the audience?
Well,
Steve.
I just would say, I'd appeal to you to make sure your audience understands that not in the trauma bay context, but in others, the flex extension views still have quite a bit.
I think that's an outstanding point, and I need to, let me emphasize that point. We're talking about initial screening for injury. Flexion extension absolutely has a purpose when you're doing follow-up evaluations, but in the initial screening, when you're trying to make a decision then.
It actually speaks to your point that you don't need more films, you need your films read better, because all 3 of the ones I've caught with negative MRIs, stone cold negative MRIs read by good people and reviewed by good neurosurgeons, there's something on the x-ray didn't look quite right. And one of them was a kid I caught that was perching on his flexion view, high school senior, and his 2 sports were football and wrestling. And
so you put the clinical context in.
Yeah, and he would have probably been hurt. Yeah, and it didn't show up on anything other than flexion extension. But
right.
I agree with you in the trauma bay.
Right. No, you make a good point, and that's something to make sure we emphasize, because I do see my colleagues when we already know that there is something off. It's that there's something off, where they'll go on and use that. Where this was driven was routine, and we're not helping things, we're confusing things. And it also speaks to the fact that MRI by default, what is the gold standard? It's really by default. I mean, because there's nothing to base it against. And to your point, you had negative MRs and you're still finding injuries on plain films.
Yep.
So we have to keep those things in mind. It's okay to go back to kind of the basics sometimes.
My experience of 3 barely rises above anecdote, really. And plural of anecdotes, not research. But there were 3 scary things.
Yeah, absolutely.
JPS, how far physically is the CT scanner from the trauma bay?
Oh, it's right around the corner.
Okay. So you just get them there 10 to 15 feet.
Oh yeah, it's right there, and there's 2 of them, which is wonderful. The issue at most places though is not the CT scanner, it's the MRI. The MRI people die there. It's a very dangerous place. And if you talk to your ICU nurses in particular, they're like, oh God, because it's always the worst place, and you're always taking the sickest patients. And and if the patient's unintubated, then it's all that, claustrophobia stuff that makes that they're trying to sedate them, and that becomes a problem. So, and John and I were fellows together at Shock Trauma, and those were things that were burned into his memory, which kind of prompted him to start looking at the MRI component of it. up in Metro, because he's up in Cleveland.
Do you have a marathon this weekend? What you're gonna be running in?
I'm on call. So the new chief, I put myself on call 3 times in the next 2 weeks. I'm like, what am I doing?
Well, thank you again very much,
Sure.
Dr. Duane. Are there any further questions for Dr. Duane? I do want to get her home. We are here to support you in your new role at JPS. We're very proud that you're here. And as you all have just realized, she's an amazing person, kind of a rock star. I don't know how you do what you do. But I do want to make one last plea. Please pass a word to everybody that you know to attend. Now, if Christmas will be over, you have no excuses. Attend our January meeting of the Fort Worth Surgical Society. These chief resident lectures are very special to the residents. It's a very big deal, and Dr. Edmondson is nervous about this already, but he's very excited about it. This is our first, hopefully annual David B. McReynolds Servant's Heart Award, and Dr. Duane's going to try and get Dr. McReynolds here. I think it'd be a great thing if we got David here. To see the award being given and hear the talk. Surgical education in the modern era, how do we maintain resident autonomy? This is a very, very big thing in the medical education. I think the discussion will go in a number of different areas, but please try to attend in this very special evening in January. With that, have a Merry Christmas. We're not going to have a business meeting, although again, please take a moment to meet Dr. Chu and Dr. Majumber. Did I get that right? Okay, tonight. And I think Dr. Duane wants to talk to you too about possibly helping over at JPS.
Yeah.
You need ENT surgeons.
I know, I need
And
some
advanced
new.
What else do you need if we can pass the word?
Yeah, well, I tried to get, Charles West was very interested in helping. His group wouldn't allow him to do it though.
So we need a vascular surgeon, we need ENT surgeons. What else do you need?
I need nice people. If you're not nice, don't apply. Nice
Well,
people.
you saw tonight you need hard-working people too, because I bet she works pretty hard. And last but not least, life is too short to live in Dallas, so count your lucky stars. Okay. Thank you all very much. Have a Merry Christmas, and we'll see everybody in January for the first David McReynolds Service Heart Award. Okay.
Christmas is over and the stock show hadn't started yet. So.
But the bad weather's here. You might as well come to the Fort Worth Surgical Society.